guys hear me? I'll try to use the mic, especially for the camera. Okay, so I am the Residency Program Director from SUNY Downstate. I went to med school at NYU, I trained at NYU Bellevue, and I ended up at SUNY Downstate for the ultrasound fellowship. By the way, we are looking, so there's a shameless plug, we have many fellowships. If any of the rising fourth years are interested, please let me know after and so I decided once I was doing the ultrasound fellowship that it was really education that I was interested in. And from there, I ended up getting a master's in medical education, I ended up becoming an APD, and now I'm the PD of the program for the last year and 2 months, and I'm not counting. Okay, so, first question. Who here has been a patient? An admitted patient? Who's sat with a family member in the emergency department, waiting to be admitted? Okay. So, I have only one disclaimer, and that this talk is not really coming from the perspective of a provider. This is me, clearly. You can see that I'm looking towards your right, but the eye with the arrow is not moving. What nerve is out?
Intranuclear or something.
Intranuclear, but that's not.
I don't know.
It's 4. So my medial rectus is out. I have a ophthalmoplegia and a partial third nerve or fourth nerve palsy. I won't explain how I got it. It's a long story. Just don't go drinking in 105-degree weather with your colleagues at ASAP Teaching Fellowship. Shit happens. Regardless of that, I say all this to say that we've all been patients, right? And so my talk to you today is from the many times that I myself have been a patient, and it's not as a program director, it's not as a physician, and so I hope to bring you to the perspective of the patient. Okay, so what are we going to talk about? We're going to talk about a little bit about research and is it efficacious to actually have a good patient-clinician communication, and clearly the way I'm saying it, the answer is yes. We'll talk about some concrete steps on how we can improve our communication. We'll talk about why patients don't actually understand, a little bit about discharge instructions, and then we're going to do an engagement piece. Okay, so first things first. What is a research study? All right, so these are just 4 articles. But basically, it says that it is efficacious, right? You can see from the first study, patients participated in their visit, and they had better metabolic control at 8 to 12 weeks, right? The next one, fourth, doctors gave out more information, and when they checked their blood pressures at 2 weeks, it was lower. When doctors were more patient-centered, patients just felt better when asked at 2 weeks. And the lower one, the Ward study, I particularly like, because this is chronically ill patients with lupus, and when they participated in their care, they had less organ damage at 3 years. So when you look at...
Sorry, I'm sorry to interrupt. Just on the previous slide, do you know the quality of the studies? Are those RCTs, and are they ED-based or are they outpatient?
They're not ED-based. Most of this is not ED-based. I will preface in saying that. But we're going to, because there's not a lot of studies, and I'll talk about a study that's actually being done across sites, but there's not a lot of studies that are looking at that. We actually don't necessarily, not that we don't care, but we have not investigated what makes our patients happy, and we are hopefully starting to do that, to merge the sector of emergency medicine and public health. And they're not randomized control studies, because you're really not going to randomize necessarily whether I talk to patients or not, and not talk to patients. Most of them are
standard of care versus sort of like an enhanced.
So they basically did observational studies on most of it, and so they surveyed them after. So your physician has now been talking to you more, and they gave the physicians a script to go by. And now that the physician is using the script, what do you feel about your blood pressure? They took some objective measures. What do you feel about your care? So none of it's controlled or randomized, because it's all based on one primary care provider, so it's like a self-selecting bias. All right, so with that said, and I'm glad you brought up the questions, because there's not great literature on this topic at all. But if you look at the proximal outcomes, so the outcomes nearest to what the patient cares about, you can see that They felt better, they trusted their physicians more, they felt like they knew what was going on, they had a better rapport with their healthcare providers, and some of this actually also comes from the nursing data. If you looked at and took a step back in some of the intermediary outcomes, they had better access to care, they started taking care of themselves better, and they felt like they had more social support. Now, if you look at the big picture in healthcare, some studies have shown that there is better survival, the remission rate is longer, less suffering, better pain control. Now, I must admit, there are just as many studies that says it doesn't work at all. It's just a waste of time, right? But I will say to you, and I will challenge you, that it's not necessarily that yes, there have been studies that shows that the more you talk to your patients, it doesn't affect the morbidity or the mortality, and they're not going to survive longer, and they're not going to be less ill. However, it's not the cure, but it's the care that you provide your patients. And so, really what this entire talk is that we may not necessarily prevent Grandma Jones from dying, but how she dies is probably what we can change. And probably the only thing that we can change as emergency physicians, right? There's very few things that we actually do that cure people. Maybe an aspirin if we can catch the MI, maybe a diagnostic study, but life is life and illness is illness and it's going to progress, right? So it's about the care you provide your patient. All right, so let's talk about some concrete steps. So agreement. I gave a talk at All New York City about a year ago, and I did some investigation into high-risk communities, mostly the LGBTQ community, and I wanted to know about how do we prevent sexually transmitted infections. And so I talked to several infectious disease doctors, a primary care doctor who works with the LGBTQ community, and their first recommendation was that physicians need to be realistic with the expectations of their patients. So we tell our patients, in order to prevent sexually transmitted infections, you should practice abstinence. I won't ask the question, but I'm sure none of us practice abstinence, right? It makes no sense to tell your patients to do that when you yourself are not doing it. All right, so unrealistic. So then you say, okay, well, you need to use barrier protection, you need to use condoms 100% of the time. And the fact of the matter is, for some patients, that's not realistic, right? Whether they're not empowered in their relationship to say that I'd like to use barrier protection 100% of the time, whether they are sex workers and that's not realistic for their clientele, whichever it may be, we're not judging, it just may not be realistic for the patient to use condoms 100% of the time. So then what do we say then? So you say to your patient, what is it that you can do? Maybe they can do PrEP, much easier, pre-exposure prophylaxis, taking a pill that has nothing to do with their partner. Maybe they can do that much easier than saying, we need to use a condom 100% of the time. So, that's a more extreme example, but you can imagine, even with blood pressure medication, maybe the patient can't take it twice a day or 3 times a day, right? Has anyone had to take medications 3 times a day? Right? Do you remember the lunch? Who remembers to take medications at lunch? It's like, and then you see your patient and you say, Ms. Jones, I don't understand why you're not taking your medication properly. Because it's ridiculous. Imagine taking something 5 times a day. Has anyone had to take anything 5 times a day? I'm sure people have. That's acyclovir, I'm sure. All right, so has anyone read this book, Atul Gawande? It's great, right? It is one of his, best books to date. So Dr. Gawande, who's a surgeon, for those who don't know, he recently, this book came out maybe like a year ago, a little less than a year ago. It's called Being Mortal. He really talks about a couple of things, really. One, this concept of how medicine became this cure state, and all we do now is cure, and a lot of what we should be doing is probably just caring, right? We don't necessarily need to run all the tests and give them all the chemo and keep doing more procedures and more procedures because it's not going to impact whether they die or not, right? But really making sure that the patient dies how they would like to die. And so that's the second thing he really talks about is autonomy. So I had a patient this weekend who was diagnosed with lung cancer. He was about 79 years old. And his physicians offered him radiation. They were great physicians, and they basically said, here's the thing, we can start radiation. Your tumor is progressing rapidly. It's, he had hemoptysis that was about half the size of a styrofoam cup when I saw him. That's huge. He could basically aspirate on that and die in a second. So they said, we can offer you radiation. You probably, have about 6 months or so, maybe a year, I can't really estimate. And with the radiation, maybe you'll get another 3 months. But how are you gonna feel during that time period? Probably awful. And so he opted to not take the radiation and to spend the time with his family, quality time that he could spend with his family. And so, allowing patients, and this is what Dr. Gwande talks about, allowing patients, especially when you're talking about elderly patients, they've lived this earth long enough to be able to make their own decisions. And sometimes as physicians or even as family members, we're very paternalistic and maybe even selfish in thinking that I don't want this patient to die. But death is not something that, it's inevitable. We're all going to die. And instead of trying to fight death, maybe we should just help people die as they want to, right? So allowing your patients the autonomy to make the decisions, even in the emergency department, with what they want to do. If they don't want a CAT scan and they don't want to know that they have some big, huge mass in their colon, then allow them that, right? Oftentimes we get upset. How could you not want the CAT scan? You need the CAT scan. Well, she doesn't want the CAT scan. All right. So, shared decision making. Now, this is really the crux of the talk. And so you'll see a lot of literature about shared decision making. And there's not very many tools that I would say are ED friendly, right? We don't really have 20 minutes to sit down and talk to the patients about whatever, right? So this article by Elwin in 2012 I found to be the most ED friendly tool for shared decision making. And it's a three-prong approach. First, you say you have a choice. So I'll use otitis media for an example. So you tell the parent, okay, your child has an otitis media. We have some choices that we can, use or we can impart to treat this otitis media. Second part of this approach is you give them the options. So here are our options. Likely, Johnny's going to fight off the otitis media on their own. He doesn't need any antibiotics. He's a healthy, 3-year-old. I'm sure he'll be fine in the next week or so. Or I can write you a prescription for antibiotics, and it's only been the second day of fever. If he has fever more than 5 days, then you can start the antibiotics, and you can make an appointment with your pediatrician. Or the third option is, well, you can, if they have a fever more than 5 days, just make an appointment with the pediatrician. They can look at them again and see if they actually really need antibiotics, right? Decision talk is the last part of this approach. So patients don't just want you to give them options, because oftentimes they'll look at you and they'll say, you're the doctor, you should know what I should do. What should I do, right? They kind of want to feel like they're making the decision, but they're being supported at the same time. So what you should say is, okay, let's investigate what this parent can do. So are you a single mom who can't afford to take off another day from work? So following up with the pediatrician is just not realistic for you? So then you can maybe adjust that. Maybe you have to start the antibiotics now, right? Do you not have someone at home to care for the child? Because the fact of the matter is they can't go to daycare with a fever. So if there's no one to care for the child, maybe this approach, which is evidence-based medicine, right? We are clearly should not be giving antibiotics for all otitis media. But the patients can't follow your evidence-based medicine. So you kind of have to practice with the patient in mind. And so you and the mother and the family will make the decision together as to what's best for them. But you've allowed them the option to make their own decision and supported them at the same time. So that's basically what shared decision making is. All right, so speak plain language. I can't stress this more, and I myself forget this all the time, right? So I was buying an apartment in Brooklyn, and I had some difficulties with the contract, and so the lawyer is reading to me what the other party is saying, and blah, 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 blah. And I'm educated by this point. I'm pretty smart. I've got a couple of degrees. I'm like, I have no idea what you're talking about. None whatsoever. And I had to remind this lawyer that if you came into the emergency department right now and I started spitting out medical jargon to you, you wouldn't know what I was talking about either. So I need you to speak clear, simple language, right? So imagine what we do to our patients who may or may not have the degrees that we have, right? So speaking clear and simple often helps the communication between you and your patient. All right. Using visual aids. This is particularly important when you're giving discharge instructions or you're explaining diagnoses, right? And your visual aids do not need pathophysiology, right? They don't need pharmacology. They don't need to hear all of that. They need to hear what's going on with them and what they're experiencing. Okay, Mr. Jones, you have a kidney stone. It's in the tubes that are connected to the kidney that go to the bladder. And every time that stone is coming out of that tube, it's scraping up against the wall, which is painful as shit, right? Not only that, as it's scraping up against the wall, you might bleed a little. Because the inside of this tube is like the inside of your mouth, and you can imagine a rock scraping up against that. That's just gonna hurt. Now Mr. Jones knows what's going on. Now Mr. Jones expects blood in the urine, right? And he's not gonna be freaked out when he sees blood in the urine, and he also knows that it's gonna hurt like hell. So teach back. Does anyone know about teach back? Right, what is it?
So you try to explain something to them, and then you have them like verbally respond to you, like what in their interpretation of what it is.
Exactly, right? So you say, okay, Mr. Jones, along with this kidney stone, I'm going to give you some antibiotics because you have a urinary tract infection. You're going to follow up with the specialist in about 7 to 8 days, and if you have any issues, you can come back to the emergency department, right? The specialist is called a GU doctor. So what did I just say to you, Mr. Jones? Oh, you said I have a virus and you're going to give me some pills for the virus and I need to follow up with you in about 7 or 8 days. No, Mr. Jones, it's not actually what I said. What I said was that you had a bacteria, because antibiotics don't treat viruses, but I'm going to give you the antibiotic for the bacteria in your urine. You're not coming back to me, Mr. Jones. Not unless you need to. Only if it's an emergency, you're going to the specialist otherwise, right? So that allows you to explain something, ask the patient to repeat back to you what you just explained, and hopefully you can fill in any gaps or do any corrective actions that you may need to do. All right, so why don't patients understand? So, in the United States, most adults read, and this has nothing to do with health literacy yet, just reading. Most adults read at an 8th grade level. 20% of adults read at a 6th grade level. So my question to you is, what grade level is our discharge instructions? Anyone, shout it out. 4th grade level? High school, okay. Anyone else? College. Have you guys read the discharge instructions? You guys have claims? Yeah. They have nothing to do with what the patient came for. It just makes you feel better. I do it too. I still do it because it documents it in QuadraMed or whatever you guys are calling it. But they have nothing to do with, they came here for a heart attack and it's talking about their toe. It really, honestly, has nothing to do with it. And to be honest, if you look at it, most discharge instructions are at a 10th grade level. Have you guys ever read the Bill of Rights for the patient? I don't understand it. And you're asking a patient to sign this document, which most people are probably not going to understand. So what does that mean? It doesn't mean that we're not, until we get EPIC, and I'm not sure how good their discharge instructions. We're not changing QuadraMed. I'm sure you guys are having an issue with that too, right? Nothing's happening to QuadraMed. So we're going to still use claims, that's fine. But that means that you need to fill in the gaps. You need to free text what you really want to say to the patient, right? All right, so now, if you can imagine the demographics, who is the patient and why that has the lowest health literacy? Now we're talking about health literacy. When you think about it in your head, who do you think has the lowest health literacy? Shout it out. Non-English speakers, okay. What else? Teenagers, okay.
Older minorities.
Older minorities, okay. Anyone else? Low income, people who are in poverty. Okay. So Kuttner did a study in 2007 and found that the person with the lowest health literacy is a white, native-born American whose native language is English. And so Jagger and Weina did a study, and they found that when they gave out health literacy tests, people who were patients who were 60 years and older did the worst. So that means that everything you guys just said was absolutely wrong. It's actually absolutely the opposite. It's not the teenager, it's not the minority,
The older.
right? And it's not the older. It's not even them, right? And it's not the person that doesn't speak English. So why? Why is that the case? Because we assume that he doesn't need me to explain anything. And you're spending so much time with the older minority explaining because you assume he doesn't understand what you're saying, right? So what is the point of that? The point is, don't assume. It has nothing to do with the amount of degrees you have, right? I just told you that if my lawyer came to me, I'm sure he wouldn't understand me. It has nothing to do with really your socioeconomics. Just don't assume, right? You can be a very wealthy person and not have any understanding of what's going on with your body, right? Don't assume. All right. So I love this picture, right? It shows that our patients have a Foley, they have an IV going, they're feeling dizzy, maybe some pain. In the meantime, we're trying to get them to sign consent for the CAT scan, right? I really need you to sign this consent for the CAT scan. What are you talking about? Well, the IV, you're giving them all the things that could happen, right, for the procedure. It's probably not a good time. So what could we do to combat this? We realize our patients this is the worst day of their life, right? So when you go to them, slow down. Don't give them all of the information that you need to talk to them about on one occasion. You can come back. I know, there's a lot of patients, I get it, but you're gonna have to come back. Has anyone ever gotten bad news? Like really bad news, like someone died, right? Or you have a bad health thing. You don't remember anything that happened after you got the bad news. So it's not likely that the patients are going to remember anything that happened once you told them they're having a heart attack. You know, they're not going to hear the consents for the cath lab. They're just not going to hear you, right? So slow down, come back on multiple occasions. Be respectful and sensitive to what is going on because it'll help you. It'll make things faster. They might be saying no to you, no, I don't want to do this, no, I don't want to do that, but it's not because they actually don't want to do it, it's because they can't hear it at that point in time. All right, and also, more importantly, use living room language, as we said before. Okay, so discharge instructions. I brought it up a little bit, but I think that once the we all do it. I do it. I think it's instinctual, but there's nothing, it's something that we have to keep reminding ourselves, right? Yelling English does not help the non-English person. Yelling English does not help the deaf person hear you. It doesn't, right? But this is something that we all naturally do. And I'm going to show you a video, and the point of the video is that, particularly for people who are born in the United States, we think our English is perfection, right? And we don't understand why people don't understand us. So I want to show in a video which I think is pretty interesting.
nice to be from India.
My name is Santiago Navarro. I'm from Mexico City, Mexico.
I'm from Berlin, Germany.
I'm from Scotland.
I'm from New Zealand.
I'm from Israel.
I'm from London, England.
I'm from Saigon, Vietnam, and this is my attempt at the American accent.
Since my husband is from Michigan, I decided I would do a Midwestern accent. Last time I went out with Brad, he spilled Faygo and Better Made chips all over me.
My name's Tim. You can call me Mitt. It's backwards for Tim.
In Minnesota, you know, all those people out there, I love hockey, man. And I was like, oh yeah, I love hockey too. I love me some good Wisconsin cheese.
Hello there. I'm from America, and I say words like aluminum and spell color without the U.
I literally love bacon. Bacon is love. Bacon is everything.
Okay, so let's get back home to New York. We like it over here. Brooklyn is in the house.
So the last time I was in New York, I was with a friend of mine called Joe. You know, he looked at me and said, "You f*** my wife."
You'll forget about.
All right, so maybe we really don't speak the best English. Maybe people can't understand us, and it's not them, but maybe it's us. So what should we do about that? Don't be offended when someone asks you to repeat themselves, to repeat yourself, right? Whether they speak English or not, don't be offended by it. Slow down, okay? Realize that we don't speak the King's English, which is probably the best English, right? Okay, so, prescriptions. Take Levaquin, right? 1 tablet, should say tablet there, once a day. What does once mean in Spanish?
11.
Old say. That's a problem. Right? And when you get prescriptions and they say to take this tablet twice a day. When is twice? Is it like an hour apart? That's not really what you mean, right? You really mean 12 hours apart. You really mean with breakfast and with dinner. Or you can just simply say, take it with breakfast and with dinner. Take it at 10 a.m. and take it at 10 p.m. Why don't we just say that? I don't understand. Why we're using Latin, first of all. We don't need to say that. Just speak clearly to your patient. And if it's written that way, we all assume that the pharmacist is going to explain it. No, the pharmacist is not going to explain it. Right? So you need to explain it. All right. So, I told you all about a sensitive time in my life where my eye didn't move. So now I'm going to ask you a very personal question. We're friends now. We've kind of broken the ice. Who here has ever smoked in their life? All right. It's a lot of you. I'm not asking you if you still smoke, and I know that 1/3 of you still smoke. That's fine. It's your business. So, with all of the medical knowledge that you have, right, you still chose to smoke cigarettes. And I didn't say weed, I just said smoke, so I don't know what you were trying to do, right? So you still smoke cigarettes. You, with all of your education, made that conscious decision. So how dare you judge the patient who wants to eat Popeyes, right? Even if they have CHF and hypertension, they realize that, but maybe they really like fried chicken, right? So we often come into the approach of, I had a resident come to me and she was just like, I had to throw away their Popeyes. I just couldn't believe it. And it's just like, well, do they have anything else, money for anything else to eat? I don't know. They just don't eat Popeyes. She's in like CHF. It's like, okay, well now you're gonna have to go and buy them and help the alternative. And if any of you have been to Kings County, you know that there's not many alternatives, right? The one salad place also sells fried chicken. So, you know, I mean, this is what our patients have amongst their community, right? It's cheaper to get the McDonald's menu, what is it, $1, $5, than it is to get Whole Foods, which is really expensive, right? Okay, so, don't judge. All right, so this article came out in the New York Times. I thought it was great. If you guys should go and archive it. It came out April, so it's very recent. And it says, okay, who is the person that I'm treating in the emergency department? So this is emergency physician. I've forgotten where he works now, and he basically said, he talked about an encounter that he had in the emergency department. We were always rushing, we had a lot of things to do, there was a lot of people in the hallway, and blah, blah, blah. And he had a patient, an elderly gentleman, and he said, okay, Mr. So-and-so, what are you here for today? And he said, well, you know, my wife died a couple of years ago, and you know, I had this young lady, she's very nice, I like her. She's better than the last young lady who took care of me. Yeah, she comes in, you know, once a day, and you know, I have my daughter and my son. My son is actually stationed over, you know, by the time he's done with this is nothing that you want to hear. Mr. So-and-so, I'm so sorry to cut you off. I have other patients to see. I really just need to know what you're here for today. So Mr. So-and-so goes on with his litany again, and he realized by the end of this conversation, with him trying to rush Mr. Jones into saying what he's here for, he realized that if he'd just taken the time, just maybe an extra 5 minutes, that he would have discovered that this patient actually is lonely, right? And is scared, because no one around him knows him, right? And all of his friends have died. And he has all these medications to take. The home health aide is not that great in helping him take the medications, and he has no idea what's going on, and he's just scared, right? So taking the extra 5 minutes to get to know who your patient is and realize who your patient is, realize where they live, what's near them, are you getting out, are you exercising, what else is going on in your life? Are you a single mother that has 100 things going on, or are you a married woman that's being abused by your husband and you keep coming to me for this cough that's nothing, but you're really asking me for help for something else, right? So take the extra few minutes. You might be the only person that this patient is able to talk to about what's going on in their life. And it may have nothing to do with what they actually came in with. All right, so this is gonna be our engagement piece. I'm gonna ask for, first, I'm gonna ask for some volunteers, but before that, at your tables, which is this nice setup, I want you, and this is a quote by Benjamin Franklin, which I love. It says, tell me and I forget, teach me and I remember, involve me and I learn. All right, so I want you to answer 2 questions at your tables amongst yourself. What is it that you most want to get across to your patients? Question number 1. Second one is, what is the most important aspect of discharge instructions? All right, so I'll give you guys 2 minutes. Talk amongst each other.
We have quite a bit of that.
Alright, 30 more seconds. All right. Okay. I'll have a couple of tables volunteer when you guys came up. All right. This middle table here. Are you want to talk? Okay, go ahead. All right, guys. Let's hear.
Sometimes we just write, oh, if you feel worse, just come back to the ER, but that's not, it has to be a little more tailored to each person and what their pathology is. There's also patients that you don't want to come back to during primary, and when it's appropriate, you come back to the emergency room. If you're discharging someone with gastritis that you are very low suspicious for appendicitis, and they continue to vomit for the next 5 days with fever, probably not the best fit for the primary versus probably come back and take you out.
Excellent. All right. We have the first question. Another table. What is it you most want to get across to your patients? Someone over here. Oh, this table over here.
I said that I try to, or my goal is to have patients feel like they've been heard and understood without like possibly having to sit down for half an hour. So like we just sit down for a few minutes and like sit down for like a couple minutes and they see that you've been there for longer. I think that also helps with their care.
Okay. All right. So I'm gonna get 4 volunteers. 4. Don't come running all at once. And faculty can come up too. 4. All right. 1, 2, 3. One more. All right. You guys can line up over here. Good. We got 1 woman. Thank you. All right. So now this section is doctors dealing with different kinds of patients. So we're going to give them a case scenario, and they're going to tell us how they would deal with this patient with all of the knowledge that I've now imparted to all of you. You're going to have to, I'll put the mic over here so you can speak to the camera. All right, so the AMA patient. You have a 78-year-old woman. She has no past medical history. She's coming in with chest pain. She's got a PhD, okay? So smart woman. You get an ultrasound somewhere along in your workup and you see that she's got a pericardial effusion. She wants to sign out AMA. All right, who's up? What do you say to this patient?
So to start, I try and get an idea of what she feels like are the severity of her condition, like her understanding of this illness episode, and what the consequences could be to her health should she leave AMA. Also, I want to get an idea of like why she wants to, what other things she has to get to that she feels like it's in her better interest to leave our care in the emergency department.
So what is it that, particularly when you're dealing with elderly patients, who can, it's almost like play the mind game. What is it that they really need to get to? Their cats, right? It's always, I've got some cats, there's no one there to feed the cats, I gotta go. Right? And you're saying, but you've got a pericardial effusion, and that's a problem, and I'm sure Fluffy is going to be okay. And it's like, well, I have to go. Right? And her cats are like her family, right? That's important to her. So what could you do if she says she's got cats?
Feed her cats.
You can go all the way to Brooklyn and feed your cats. That would be amazing.
Her phone, possibly a friend, give her a phone. If you call a friend or a family member to go feed the cats.
Exactly. Help her find the neighbor or her friend to go and feed the cats. You might save this woman's life just if Fluffy gets fed, right? It's amazing. Okay, thank you. Next. All right, next person. The drug seeker. All right. Yes, and I will say the little caveat is we should not be identifying our patients by their condition, right? This is actually rude. We shouldn't be doing this. All right, so 34-year-old male, ex-heroin addict. He's been clean for 6 months, so he still qualifies as an ex-heroin addict, all right? He's got a right fifth toe injury. He was playing basketball. We find that there's a fracture there. He states that the Motrin you gave was really not working. He's allergic to Tylenol, Toradol, Tramadol. You want something strong for this pain. How do you do it?
I would explain to him that narcotics are heavily regulated and monitored by the government. We have a hospital policy that the prescription of a small number of opioid medication is reserved for long bone fractures, which he does not have, kidney stones, and cancer.
You're not going to give him a prescription of anything. Are you going to give him anything then?
I will also give him an ice pack. I will give him a hard-soled shoe, maybe an ace wrap if I think that'll help also to facilitate, and a cane.
Okay. Anyone else? And a Metro card. That makes sense.
Good job, Stephanie.
Say that again?
Good job. That's a chief answer.
Take the Motrin around the clock. Okay. Anyone else?
What about like a digital box? What about a digital box?
A digital block. Yes, that might help. Now, it might not help for tomorrow, right? But it might help for today, and it might get him out of there.
Just long enough to walk out of the
Just long enough to walk out of the emergency room, right? And maybe once it's not hurting and he can't feel it, maybe he will just take the Motrin, right? Maybe it's synergistic as well. All right, so there's some other things that maybe we can do and offer. Okay, thank you. All right, so who's next? This one is special. This is definitely special. This one comes with a video. How do you deal with this family?
Bebê corajoso, Pianeta. Olha aqui, ó. Ele. O papai aqui, ó.
You're in pediatrics.
No.
Right? Gotta draw some blood.
Nem chora porque não é forte. E bebê mais velho. Mas não
I like to get to the end because I like to show that he's crying so much he's choking. Alright, so you have this family. And it's a family because where is the mother? She's filming, right? She's seen this before, and she thinks it's ridiculous. And she's going to post it on YouTube because she wants to show everyone how ridiculous he actually is. All right, so you have this family, and you need to get blood, and you know what happens, right? It's the family that, this is the family that you're going to get that the blood, the IV doesn't go in, and you're like, shit, I have to do it again. And they're like, I just can't possibly see you stick my child again, right? So how are you dealing with that?
Well, for me, the preparation starts before actually bringing this stuff by. I talk to the family, I say, hey, everybody in this room, after today is gonna have a shot, well, or at some point in their lifetime. And I tell them mommy's done it, I tell them dad's done it, and you want to be just like parents when you grow up, so let's go ahead and try this. I show them the things, I say, this is where I'm going to place this, right in this place. I try to talk everybody through it, even to the little kid, I say, hey, you know what, you're going to be strong. I try to make it seem like an experience. And then once I get down to that point, and the kid is screaming and crying, I try to tell him that he's going to be great, he's awesome. And as soon as it's done and family wants to like strangle me and choke me or whatever, I say, hey, I'm sorry, but it was necessary to get this portion done. And I tell the kid how excellent he did and how proud of him I am. I try to come in the room and give everybody stickers.
Anyone else? That's That's great. I want to get a shot at that. Anyone else? I think I heard it over here. Yes? Please, ask him to leave. Right?
Well, that dad? Oh,
That
you got-
dad, he's not
you gotta
strong
go to the
enough to deal with this situation. Ask mom if she can handle it, and because maybe she's stronger. But maybe you have to get them to leave, right? It's like, listen, you might not want to see this. We have some nurses to hold the baby, but it's absolutely necessary. We've got to do this, right? Just ask them to leave, right? And talk to them sweetly outside of the room. Give them a sticker, maybe an ice pop or some juice, and calm them down, right? Because it's the kid. It's like you can hold on to that kid. It's the dad is like, what are you going to do? All right, good. Thank you. That was a difficult one. All right, so now the agitated patient. All right, so you have a 65-year-old male. He's admitted for shortness of breath. He's got some EKG changes, a positive trope. He's been boarding in your emergency department for 48 hours. I don't know if you guys have this. I'm sure you do. Yes.
It's usually longer.
Yes, I know. Right, so first day comes and, you know, he's admitted overnight. You know, I'm summarizing this case. And basically, cardiology wants to get him a TEE. So he has to be NPO, right? So he eats up until 12 midnight, next morning comes, it's like 3 p.m. and he's been NPO. And he's like, what the hell, I'm starving, right? Are you starving me? Are you purposefully starving me here? And so you call and it's like, you know, 3 p.m. We can't fit him on the schedule today. So finally he gets fed somewhere around 7, 8 o'clock, right? Next day comes, he's NPO again. Now he's threatening to sue everyone because it's like, you starved me for 2 days. I came here for chest pain. I'm getting more chest pain sitting here, right? So now how do you deal with the patient?
It's tricky. Well, the first thing I guess you could do is like validate. I would validate his frustration. Be like, sir, you know, I'm sorry that sounds very frustrating. I would be feeling the same way if I were in your position. I guess the first thing you know, let me call and see if I can find out what's gone wrong. Like why this keeps happening, because ultimately I'm not the one doing the scan, so I don't have total control over this, but what little power I have to influence this, I will try to call and get in touch with the people doing it, and you know, make sure, and if it's not going to happen today, I'm going to find that out for you so that you're not being NPO until 8 o'clock again, just to find out so they're not going to fit you in. Sometimes that, like, validating it can help.
Yes, no, definitely saying, I understand, right? This person is just not psychotic running around, you know, acting like a crazy person. He's hungry, right? We all get hangry at times, right? It happens, it's natural,
You're
right?
not you when you're hungry.
Exactly, right? We need a Snickers or something, right? So, you know, we understand what's going on. So I gave this talk at an Emergency Nurses Association in the spring, and you know, I said all the things that you said, that's what I had in my mind. And then a nurse was like, you know, one of the things that really helps is saying sorry. Just, that's it. Just saying, I'm really sorry. And, you know, identifying that it's not someone else's problem, it's all of our problem, and the system has done you wrong, and I really apologize, right? And then you can proceed to acknowledging that I completely understand, I'd be upset too. Why are they starving you? I don't get it, right? And so trying to figure out what you can do and then calling the service. Okay, great. Thank you volunteers. Thank you very much. All right. So now we talked about how doctors deal with different kinds of patients. And we're going to wrap up by talking about how patients deal with doctors. Okay, so this goes back to doing some research to see, you know, what our patients actually want from us. And so what we did was, for one shift in the ED, we passed out cards. And this study actually was done at WASU, and we're going to try to replicate it at our site. But we just did it for, you know, a test trial for one shift to see what we could get out of it. Basically, we asked the patients 3 questions. So we have and they're waiting in our waiting room. 55-year-old female, she's coming in with chest pain and shortness of breath. We ask her, so what do you hope to get across to your physicians on this visit? Not, just generally speaking, not very specific about your illness. And she says, I want to get better. We say, okay, well, what are your fears? I'm afraid to die. How can we most help you today? Help me figure out. This father is coming back. Okay. Help me figure out what's going on and if my heart is okay. Next patient. 76-year-old male, he has a history of hypertension, end-stage renal disease, prostate cancer, coronary artery disease. He's referred from the Cards Clinic. He says, okay, so what do you want to get across to your physicians today? He says that the different illnesses are related and physicians are not dealing with them all together. What are your fears? The same as the above. How can we most help you today? Give me a plan that we can work on together. All right, 58-year-old female with chest pain. What do you want to get across today? I'd like to know what's causing my pain. What are your fears? Heart problems, lungs, cancer, kidney, liver. How can we most help you today? Give me something to ease the chest pain. I'd like to know, is everything okay as a diabetic? How are my organs? Are they functioning? 34-year-old transplant patient with a fever and throat pain. What do you want to get across today? What kind of patients they are treating? What are your fears? I fear the most if they can't help me. How can we most help you today? By giving me the best care possible for my condition. All right, so that's your patients talking to you. I'm sure your patients are the same as my patients across the bridge. They're the same fears that you and I have, right? If we were patients. Particularly if we were patients who don't have all the education that you have. These are our family members, right? It's your mom who's texting me now because my nephew has cellulitis in his leg, right? They don't know what's going on. So you should treat them just as you would want to be treated and just as if they were your own family. Okay, so in summary, improving the clinician-patient communication. No, maybe the studies don't really pan out, but it doesn't hurt your relationship with your patient to take that extra few minutes. Some steps that we talked about, concrete steps to actually improving that communication, making sure your treatment plan is in agreement with what the patient can actually do, autonomy, allowing them to make their own decisions, even if that decision is against what you think is best, shared decision-making, giving them options and helping them and supporting them to make that decision, speaking plain language, using visual aids, especially when you're talking about discharge instructions and their diagnoses, and doing the teach-back system. Health literacy starts with not assuming they understand you, right? Keep your discharge instructions simple and do not judge or you too will be judged. All right, thank you. I have like 10 seconds. Any questions? You can email me your questions too because I think I'm already over my time. Thank you very much for having me.